Well, good afternoon, everybody. Thank you very much for coming along to this event as part of the Evening Standard Stories Festival in association with Netflix. And our title is Under Pressure, Stories from the NHS Frontline. And it has been the most astonishing year and a half or more for the NHS, for all of us in society because of the pandemic. So this is a very timely moment to have this conversation. Of course, the NHS was under huge pressure before the pandemic, and that I think could be one of the important themes that comes out of today. So I'm delighted to welcome on your behalf 3 doctors who saw the different pressures on the front line from different perspectives, and who will provide us with a fascinating insight, often moving insight into what they've experienced and what the implications are for all of us. So to my immediate left, Dr. Rachel Clarke, a palliative care specialist in Oxfordshire. She's written Breathtaking, which covers some of her role in a hospice during those extraordinarily difficult months in the first wave, and also working at times on the front line at the John Radcliffe Hospital in Oxford. Then one along, Dr. Amir, a West Yorkshire GP, who has written The Doctor Will See You Now, with all sorts of insights on life as a general practitioner in all its glory, many happy, many sad, many very important stories. And on my very far left, Dr. Kathryn Mannix, an end-of-life specialist who's written Listen. She has played a very important role in One Trust and more broadly for the NHS on end-of-life care and dealing with some of the really difficult issues around that during the pandemic. So first of all, I think I'm going to ask all 3 of you your memories of those early weeks in March 2020 as it became clear that something appalling was about to hit the UK in the shape of the pandemic, COVID-19. Rachel, there's so much in your book about what happened, but when was it that you first began to realise how serious this was?
Well, unusually early in a way. I had a vested interest because my husband's a pilot, so he was flying backwards and forwards in January and February last year to China and northern Italy mainly. And of course the pandemic began in Wuhan, and then we had the horrendous experience of Lombardy in northern Italy being completely overwhelmed a couple of weeks before we were. So I was following this very closely, and from my perspective it just looked like that awful sensation of a car crash happening in slow motion and you're trying to hang on to the steering wheel but everything's getting out of control. And as the weeks went by, more and more and more the gulf between the sort of clamouring dread that doctors and nurses were feeling versus the apparent complacency on the part of the government and understandably the population at large was really distressing, and I think it culminated for me a couple of weeks before lockdown was finally declared, when here in London, Northwick Park Hospital was so overwhelmed by COVID patients that they had to declare a critical incident. They had to close their doors to patients and start farming out patients from ICU to be sent to other ICUs, because A, they'd run out of ventilators, and B, the entire hospital was on the brink of running out of oxygen. And that happened some 10 days or so before lockdown. So it was unbearable knowing what exponential meant, knowing the cases were just at the beginning of going like that. And yet we still, as a country, weren't doing what we needed to try and stop what was going to be a calamitous loss of life. And I think in a strange way, it was almost a relief when I started going into the hospital and looking after patients, because I could just focus on this patient and then this patient and then this patient, and I could do something that anaesthetised me a little bit from this profound distress. I mean, I couldn't sleep at all. I was so horrified by what was unfolding.
And Amir, you write about how suddenly it became clear in general practice, in your surgery, that everything was going to change, and you had to divide patients up, and you had to go to a different practice, and it was really a huge jolt, wasn't it?
It was, yes. So about the same time that you were doing that, we were looking at our waiting rooms as partners in this practice, and it was full. It was still full, and we were thinking, gosh, we cannot allow this to happen, because we had pregnant women in, vulnerable patients who were coming in for bloods because they were on drugs that suppress their immune system, a real hodgepodge of kind of people all in this one area. So we made a decision overnight, really, that we're very lucky. We've got quite a large practice, and it's spread over 4 sites across the city. So we made one of our sites a red hub. So we would see anyone with a potential COVID symptom, so a cough, fever, anything like that over there. And other practices around Bradford got wind of this and asked us whether we would see their patients there as well, because they didn't have the sites that we had. And we said, yes, of course we would. But what that meant was we were getting a large number of patients coming in who weren't unwell enough really to go to hospital, but may have COVID, may have something else respiratory related, and we had to decide that. But we didn't have any testing or anything
or PPE.
Or PPE. I mean, we had the mask that you're wearing now, and we had these plastic pinnies, which I still don't know what job they play at all. We used to call them our magic aprons because nobody really knew what they did. So I remember, and I write about this in the book, really, is my first shift in one of these red hubs, going in, and I had the news on, and it was when the cases in Italy were really skyrocketing, and we were learning about clinicians getting affected by COVID, and specifically in this country and beyond, really, we were learning about people from minority backgrounds getting affected disproportionately by COVID. And so that really hit me hard. And I've never in my life been afraid to go into work. Normally I'm quite cheery. I quite like going into work. I like saying hi to everyone and the patients. But it was the first time. And my feelings were kind of juxtaposed against the kind of the messaging coming out about healthcare professionals being heroes and warriors, and that felt really uncomfortable for me with the way I was feeling about going in. And then when I got there, I felt really inadequate, because there was the receptionist and there was a nurse there who were completely fine about being there. I seemed to be like the only one nervous about it. And they were like, "Do you want a cup of tea, love?" And I was like, "Yeah, but can I have another apron?" And so it was really bizarre. And we had these really odd instructions from our clinical commissioning group about how to manage patients in these rooms with COVID-type symptoms, and they were just really obscure. Like, when you're listening to their chest, make sure they turn away from you so they're not breathing on you. And when you're examining their abdomen, it's the same thing. Make sure they're looking away. And so when you're examining a patient, so we had a full list of patients, and you say to them, "Oh, do you mind just looking over there while I examine you?" The first thing they do is turn towards you and go, "Sorry, what did you say?" And so you get a full whiff of everything. But it was a completely different way of working. So one day I'd be doing that, the next day I'd be going back to the bigger surgery and seeing patients with non-COVID related symptoms. Of course, we had to implement a level of triage and remote working as well for those patients who could be monitored at home. And then, of course, there were the nursing homes, which I guess we're going to talk about later.
Sure.
But yeah.
And just for both of you as frontline clinicians, that PPE issue was really scary, wasn't it? And it became a huge issue in those early months. There wasn't enough.
It was horrific. It was absolutely horrific. So I was in the hospital where I was very lucky. Our hospital had good supplies, but also the hospice was counted for PPE purposes as a care home. So that meant literally, and this applies to every single care home in the country, in March last year, every care home and hospice in the country was issued, and GP practice was issued with one box of PPE that contained a roll of magic aprons, a box of gloves, and one box of the paper masks that a lot of you were wearing now in the audience. That was it. And it was absolutely remarkable. And this was at a time when we started to have colleagues, friends getting sick, being admitted to hospital, going into intensive care, and dying from the disease that you daily were going into work to treat. And I mean, I remember the first time I cared for a COVID patient. I put on my PPE and I went into the room, and I had something I had never experienced in my life before as a doctor, this real determination to go in and do the best job I could. This was a pandemic. You want to step up, you want to help people. The patient was very, very, very sick indeed. But at the same time, I was slightly recoiling. My body was kind of recoiling, even though my mind wanted to go in, because I was afraid this was the disease that was killing everybody, and I was going to be in a tiny little room with no ventilation, right up close to this patient. And it's impossible initially not to be afraid of that, but everybody very, very quickly just accepted it because it's your job.
But I think it was being said by ministers, the nation never ran out of PPE. What's your response to that?
We came very close to running out of PPE, and we were rationing PPE. So, whereas, when I was in the Red Hub, yes, we had to wear PPE, and really we should have done when we were seeing non-COVID related patients as well, because they could be carrying the virus, but we just couldn't do it because we didn't have enough PPE there. And that's for their protection as well as ours. I think there's something really strange about putting on protective equipment that isn't going to protect you. There's just something really weird about that, and that the standards by which they have one country has one set of rules for what is PPE. The World Health Organization had one set of rules, and then Public Health England seemed to change their rules in terms of the availability of PPE. And in your heart of hearts, you just knew you were putting on something that really wasn't going to make a difference to you or the patient, and that was really difficult.
So, Kathryn, at this moment, early in 2020, you'd left the NHS, but given your expertise on some very difficult issues around end of life, something had to be drawn up, didn't it, with coronavirus claiming lives in hospitals and outside, about how you deal with this from a staff and patient and family perspective.
Absolutely. So we were sitting at home watching this situation evolving and feeling the dread and the horror, watching what was happening. And in Lombardy particularly, there was information shared by colleagues in Italy with colleagues in Britain. So perhaps, in fact, medical and nursing staff were ahead of the game in understanding what lay ahead and the risks. And by then, I was retired. I'm campaigning for better public understanding of dying. And suddenly, mass dying is coming at us like a train. And it didn't seem to me that I could sit at home with that. The GMC offered to re-register all doctors who had retired within the previous 3 years. So I had an email from them to say, if you want to re-register, follow this questionnaire and we'll find you a job. And the job that you end up with is telephone triage of people who are hot with a cough, which was a really important part of what happened, but didn't seem to be the right place for the skill set that I had. So I was given a job initially while I was waiting to re-register by NHS England with a small group of people to elaborate a training program and a set of suggestions for holding those really delicate and sad conversations where at this stage families were not permitted to visit even the bedsides of dying people. Staff who were not used to looking after people who were dying were now looking after dying people, and they were having to communicate with their families the very best way they could, because every single person brings their best self to this, and it's really important to understand that. And by repeatedly giving your best self to these really, really emotional conversations, staff were becoming exhausted. So what we did was to use conversations analysis research to develop a framework to enable staff to make the phone call, check that they were talking to the right person, and that the person they were talking to was in the right place, not surrounded by the children of a person that they were just about to announce the death of, not in the vegetable aisle in Tesco's, to be in the right place for that conversation. And then rather than just punching from out of the blue, to invite the person you're talking to explain what they know already, to just check that they are already expecting that things aren't great. And if not now, to start to add information that starts to tell a story, so that if there's unwelcome news like this person's tested positive for COVID, or this person is struggling to breathe and we're moving them now to the intensive care unit, or this person is so sick that a ventilator won't help them now and we're offering comfort and care, but we think that this person you love is likely to die, that actually they're telling a story that helps people to absorb that information and not be doubly shocked by the way that the news is broken. And we managed to turn that around, making videos on our own phones at home, the sort of things that you notice afterwards are that you didn't tidy the living room properly. So that these were kind of coffee break chunked size advice videos, 4 of them, about different aspects of these conversations that all staff could avail themselves of while I was waiting to re-register and then go back into work.
Because as you've touched on, there were no visitors allowed. So each hospital, as I understand it, I'd be interested to talk to Rachel about her experience of this, but having to put families in touch with somebody in intensive care, a loved one who might only have days to live, put a huge strain on the family and the staff at the hospitals.
Indeed, and certainly the hospital that I went to work in very quickly had tablets for each of the wards so that they were able to have virtual visiting, and they used staff, volunteers, medical students to help to be at bedside so that clinicians weren't diverted from the clinical task of looking after people. But people who are really sick don't have the energy or the concentration to have conversations by phone or on a tablet. And if you're trying to talk but you've got high flow oxygen going, then it's very difficult to hear on the phone, and the high flow oxygen itself distorts what you're trying to say. So very often what we found, and I know that Rachel will have had this experience, is that staff become the go-betweens in those conversations, and those really tender and intimate things that people are saying at the end of their lives, their thank yous, their farewells, their I love yous, were needing to be heard by a member of staff and said to the other person, and then reciprocally. And that, again, has been a revelation to staff who are not used to working at the bedsides of dying people, and for everybody it felt intrusive and difficult to be there, and yet an enormous privilege also to be part of those conversations.
I mean, Rachel, I think you touch on this and explain there are some newly qualified medical students who were suddenly doing this role with no training at all.
Absolutely. So in March last year, when we realised it was all hands on deck and anybody who could help was valuable, particularly in the hospitals. In my trust, we had over 100 final year medical students, all of the medical students, about 400 of them were asked if they wanted to volunteer. Every single one said yes. And the final year students, especially who were almost doctors, they were going to qualify a few months later, they all were allowed to qualify a little bit early, and some of them became the go-between person either on the wards or in intensive care. So they would be communicating daily with a family to update them on how a loved one was doing. And very young, early 20s, sometimes no experience of this at all, and they stepped up absolutely magnificently, but really incredibly difficult to do. I think one of the hardest things was not only becoming the kind of proxy family member at the bedside, as you described, Kathryn. So the number of times I would sit with somebody who was dying and I would hold their hand, even though we were only meant to touch a patient when it was strictly necessary. I believed it was strictly necessary to hold their hand through my gloves, be really close because of the noise of the oxygen, and report the words that their mother or husband or wife had said, and impart those final messages was absolutely heartbreaking. And also, I don't know if the word privilege is quite right, but you just tried with every fibre of your being to do a good job of communicating all of the love and all of the sincerity as best you could, because you were all the patient had. You were never going to replace the loved one, but you were all they had. And I was always so conscious of the fact that from the patient's point of view, if a patient came into hospital and died of COVID, from the very moment they went inside the ambulance, every single person they would see from that moment onwards would be masked. They would never see somebody smile at them again because we were all wearing masks. So you had to find a way of conveying humanity and care and love to that patient. And I think you can do that with your eyes, you can do that holding a hand, you can do that just by talking to somebody, you can do that so simply. But it was glaringly, obviously, one of the most vital medicines we were providing at the bedside at a time last March, April, when we had no medicines, no true medicines for COVID. We could give patients that, and that meant a lot.
Really important and heartbreaking stories that you've referred to. Amir, you saw something similar in care homes that you went into, didn't you, with patients who had the virus and you couldn't really do a lot more.
No, care homes were very difficult. We had patients discharged into care homes. We also were told that really, unless it was absolutely necessary, we wouldn't be able to admit patients from care homes. So we were really stuck as GPs, and we had a really good COVID at home team, which we set up through primary care, and part of that were us GPs, but district nurses and community matrons. So we would be looking after them in care homes, and it was really tricky. Our practice, again, we look after a number of care homes, and we'd go in. We know they had COVID, but there was very little that we could do. We could talk to them in the same way as you're describing now, and keep them as comfortable as possible through the medicines that we had, and that was just focused on comfort really than treatment. And I think the difficult thing was really, we would have these very very intimate, very serious conversations with family members, which we're trained to do, but we're trained to have them face to face. But we would always bring them in. Either I'd meet them at the care home or I'd bring them into the surgery and talk to them about their loved one that way. But we were having them on the phone or via video phone. And I think that felt really difficult in a number of ways, but it was I guess the frequency at which they were occurring, which was the most difficult, because they are very emotional conversations for us to have, and we have to recognise the impact that it has on us as people, and the number of times you're doing that each day does take its toll, and it certainly did for me. And I think, again, when you've got family members really begging you almost to send their loved ones into hospital and you can't, it is really, it adds an extra layer of difficulty to that conversation. And I'm a very experienced GP. I've been a GP for the best part of 12 years, but we had very newly qualified GPs having to do that as well, and that was hard. And GP trainees and the toll it was taking on them was very difficult.
I mean, we'll come on to some of the things that have happened since, but one of the costs of all this has been in terms of care that wasn't provided because of COVID and the NHS being completely focused on that. And one of the terrible tolls was on mental health, people living at home on their own and unseen consequences around that. And we've seen an increase in demand for services. Kathryn, how do you see that? And you talk about loneliness, I think, towards the end of your book as one of the things for society to try to think about more.
Yeah, it's an interesting thing, isn't it, that loneliness, if you've never been lonely, seems to be about being alone. But loneliness is actually about lack of connection. And so a lot of people had an experience of being disconnected during the lockdowns that we've experienced. And we found a variety of ways around that disconnection. But not everybody's been able to avail themselves of the technology to do that, and people have become left behind. And we already know that people, for example, who are hovering on the edge of depression and descending into a state of depression, feel more hopeless and helpless about taking actions, so they don't take the action to reach out and make the contact which might in fact start to lift them. So it's a silent epidemic, and I think what we've got now is a pandemic of death and changed life expectations from people who are struggling with long COVID, for example. We've got a tail behind it of delayed diagnoses and delayed management of other physical illnesses. We've got a bereavement pandemic sweeping both of those difficulties up. And then we've got a silent mental health pandemic also sitting, waiting for our attention. I think it's going to be a long, long time before we're able to be stable about these things.
And you've got exhausted staff in the NHS, both in trusts and hospices and in general practice.
Yeah, and at the moment it's quite tough at the moment in the sense that we're very familiar, sadly, with every January having an NHS winter crisis. We're used to the ambulances queuing up outside. That's been happening since the middle of summer. In August, my hospital has been on black alert routinely. It was on black alert again just over a week ago. We're seeing images now coming out of patients in Addenbrooke's this week who literally at night were queuing up outside A&E in the car park. They'd been seen, but there was no space for them to come into A&E. That's such as demand, and of course demand in general practice overwhelming. So staff now very depleted and exhausted, and many people feeling quite broken by the experiences of caring for people in the pandemic. We're frantically trying to catch up on the backlog of all of the other care that had to be put on hold. We've resumed all the operations and so on that were put on hold. But it's terribly difficult to do all of that, even if you're feeling as strong and resilient as you do at your best, and people aren't, and a lot of people are leaving the NHS at the moment. So all of which is a pretty bleak assessment of the state of affairs, and I just hope people are listening to that and figuring out what to do about it.
To emphasise the positives, the NHS has come a long way with intensive care medicine, looking after COVID patients. There are therapies and drugs, and there are techniques, and of course the vaccine programme. So, I mean, given where everything was in March 2020 and where we are now with COVID, I mean, would you? It's not over, but
No.
but the NHS has done a fantastic job in so many ways.
Absolutely, and you know, I basically think, yes, that's true of the NHS, but actually I think that's true of the country. I think the country has done an amazing job through this pandemic. Every single person in Britain has lost something. People have lost their lives, their loved ones, their confidence, their peace of mind, their social life, their mates at school, their mental health. Everybody has lost something, even their jobs, you know. And all of us have been kind of grappling our way through this period of unprecedented loss and trauma, and our whole lives being turned upside down in a way that I never anticipated living through. And in my experience, the thing that shines through, as well as the vaccines, the treatments for COVID, the ways in which key workers stepped up, it's more fundamental. It's that actually, when I looked around myself last year and all the way through, by and large, I saw people just bravely doing their best. And that might have been setting up a WhatsApp group for all the vulnerable old people on their street, or doing an NHS clap, or donating some pizzas to the hospital. Whatever it is, basically everybody I knew was trying to do something good and decent and generous and loving for vulnerable people in society, and you just saw a wave of that just rippling across the country. And every single day I went to work in the hospital, patients, family members and staff were so brave and so decent and selfless and generous and thinking about other people, not themselves, that I have come out of it with a far more just heartfelt sense of what people are and what they're capable of than I ever did. And that's why I feel optimistic. I think people blew me away during the pandemic. Everybody, from, grassroots upwards, amazing.
Really heartwarming, wasn't it?
Yeah.
In so many ways. Amir, you were very much involved in the initial rollout of the vaccine programme last December. And you had challenges, didn't you? Because it was winter, and some of people coming in dressed for winter.
It was, yeah. So it was a turning point for us at our practice when the vaccines came, and when we put out a call for volunteers for the vaccine clinics, we had no shortage of volunteers. In fact, we were all kind of clambering over ourselves to do it, because it was just so exciting in a way that there was something there that may change the course of this pandemic. And I remember we set up the first clinic, and there was a real sense of camaraderie in these vaccines clinics. It's just incredible. It's different to any other kind of, when we do the flu vaccine rollouts every year and all of this, it felt very different. Everybody was really excited. There was a ton of biscuits, and what we didn't anticipate, because we had so many patients to get through, and the vaccines are really volatile in a way that they can only be out of the fridge for so long, and each vial has a number of vaccines in it, and you have to use them within a certain period of time. And we had someone in who was observing all of that and making sure that we stuck to those things, and we didn't want any vaccines to go to waste. But the first group of people, I guess, that we invited in were the people who were all 85 and above. And this was December, early January, and these people hadn't been out for such a long time. So they themselves were very excited about being out. So everybody in the room was excited, really. And we only had 3 minutes per patient per vaccine. And also, as well as having to vaccinate them, we have to input all their data into this new system which they designed, which was completely separate to our normal computer system. So we had to input names and date of birth and NHS numbers all manually, so it didn't pull it across like now it does. They've updated it, thankfully. And so these poor 85-plus-year-olds wanted to come in and really wanted to talk, because they hadn't seen us for ages, and they wanted to tell us what they'd been doing, what we'd ask us what we'd been doing, and also they were wearing about 5 layers of clothing because it was cold outside. So they were like, "Oh, Dr. Khan, can I ask you this? Can I do that?" And I was trying to strip them as they were talking to me. And I was like, "Just need to take this down. No, you could leave that bit on. That's fine. We could roll that one up." And it was all kind of part of it, and it was a really nice experience. It was lovely. We ran late because these people were, they're not the quickest as well, but it was just a really positive thing. And then as we moved down the age groups, things got a bit quicker. And then when we got to teenagers, they wear next to nothing, don't they? So it was really quick. But it was a really positive thing. And then I was responsible for going into our care homes, and vaccinating them, and our homes with patients with learning disabilities as well, and that was a completely different experience, but really positive in its own way. And there was something really tangible and palpable about doing something with immediate benefit, I guess, with vaccines when you're going out to these homes. And yeah, it was just an incredible experience to be part of, particularly in those early stages.
Right. Kathryn, you were dealing in an area which isn't exactly going to have that many lighter moments, but were there moments that really either entertained you or gave you a real lift?
I think one of the biggest lifts was we had a cohort of these very new junior doctors, like Rachel was talking about, and we decided we were going to, in the trust where I was working as a staff support worker, we were going to run training for these complex conversations, and the trust was all set up for doing everything online, so each junior doctor could be safe in a room, didn't need to wear a mask. And I just thought, I don't want to do it like that. I want them in a lecture theatre where I can see if any of them is looking wobbly. This is really big, this is really hard, and we need to look after them like that. So we had a lecture theatre that's a little bit like this one, and as they were coming in, we were asking them to come in, they all had their masks on, and sit in socially distanced threes, in little triangles, so they'd be able to listen to the preamble, which was a palliative care doctor or me and one of the palliative care nursing team, and a little bit of skills demonstration, and then they were going to have goes in their threes, swapping roles. And what was really remarkable was the gusto with which they set to. And you suddenly realise that actually, because everybody is working in these hot zones, in these red zones, covered in PPE. They were not seeing each other. They'd been a cohort who was supporting each other, and now they were all on different wards, aligning themselves with new teams who were doing their best to support them, but it was so very busy. And we delivered the first few trainings, and we'd planned to run 6. By the time we'd run the second one, we had a waiting list of 30 people who were not the newly qualified staff. By the time we'd run 6 of them, we had a waiting list of 200 people. And eventually we were running them in lecture theatres with the head of ICU, the respiratory unit, people who I would have gone to for training about talking about breathlessness. But what they wanted partly was that reassurance of having a framework that said, yeah, we're in this together, and partly the chance to be able to come and do something together that wasn't patient-facing. So I think the thing that was wonderful for me was that by the end of, 600 staff coming through, what we've done is said, this is a conversation that's about humans. It's about humanity. It's not only a conversation for a doctor to have with a patient or with a patient's relative, that this conversation might fall to any of us as human beings, to have to break unwelcome news and be a person's companion as they take it in, and that we're gradually changing the assumptions of the whole workforce by doing that. And I find I'm really uplifted by that change.
Right, fascinating. And Rachel, there were some absurd moments, weren't there? I think ventilators was one of them. When you were desperate, they were desperate to get ventilators in those early days.
Yeah, I mean, I think maybe a lot of the news coverage of the pandemic was very much about the high-tech end of things, ventilators, and can we build new ones, and can we come up with incredibly sophisticated drugs to treat COVID. But in the early days, when everybody in the NHS was just frantically doing whatever they could as quickly as possible to transform the whole of the NHS root and branch, we had to sort of rip up our A&E and divide it, carve it up into a hot zone and a cold zone. And so red tape, you would see it literally going down on the floors, and you'd see men in hard hats all over the hospital frantically building barriers and making new pathways. It was incredible. But in the midst of all this frantic activity, because we were really racing against the clock, some pretty desperate things happened, and which made me feel as though, goodness me, we think of NHS underfunding, but the Heath Robinson aspects of NHS pandemic preparation were sometimes just hilarious. So in my hospital, everybody had to have a special COVID hub, a pod outside the hospital. So if someone in the early days came off a plane from China and then got a fever, they weren't meant to walk into A&E, they were meant to go into the pod, and they could be assessed there, and it was all hermetically sealed. We didn't have a pod, so we couldn't even get a porter cabin, a spare porter cabin in the hospital. So there was a point when the head of A&E literally had a discussion with the department saying, okay, there is nothing, so I'm just going to order the biggest shed that B&Q has, and we'll put that outside A&E. And then the embarrassment of that, I think someone realised the PR might not look that good for the trust.
BBC might have heard about it.
Indeed, I might have even tipped them off, and they procured a porta cabin. And then another time, somebody in the trust was responsible for trying to procure ventilators from anywhere, because every single one we could get potentially was saving lives. And so he's a half American, so he had a very wheeler-dealer kind of background. He was speaking to businesses and charities and the university, and he got through to someone. Oxford has a big physiology department, and experiments are conducted on animals, including primates. So he got a call from one of the professors from the physiology department saying, I've managed to get you a ventilator. I've got you one ventilator. And the doctor said, well, that's absolutely fantastic. And then the professor said, yes, it's a ventilator for a macaque monkey. And macaques are sort of the size of a human baby. So he's had to say, no, that's probably not going to help that much. So that kind of thing kind of went on all the time. And it gave us a little bit of a morale boost, the absurdity of it. You had to have something to laugh at.
Indeed. And Amir, your book is full of the rich tapestry of life as a GP, with very sad stories, but also again some very sort of what am I trying to say? Lighter moments, which are absurd in their own way.
Yes, yeah. I mean, I think when I wrote the book, I mean, most of it was written before the pandemic, and then I was coming to an end, and then the pandemic hit, and I thought, gosh, okay, things have changed, so I've got to address that. But certainly before, you know, there are some, because you see a different person comes in every 10 minutes into general practice, so you're going to see a variety of things, and I think one of the funniest things in the book for me really was, and it's not that funny actually when you tell it, but it was funny at the time. But we're a teaching practice, and I train medical students and GP trainees, and I had a student in with me, and he was an international student actually. He was doing his elective in Bradford, bizarrely. I don't know why anyone would choose to do their elective in Bradford, but he had, and he'd come over from the Middle East, and I was on call, and it was one of our branch surgeries, which is relatively small, and it was just me and a receptionist there. And the receptionist came in. It was in the middle of the summer, and it was fairly late, and we were almost wrapping up to finish. And she said, "Oh, a mum's walked in with a child, and the child's got a rash and a fever. Would you see them?" And I was like, "Yeah, fine, absolutely fine." And I said to the student, "I will show you how to examine a rash in a child, and how to see the difference really between a serious rash and a non-serious rash." And he was totally up for it, very eager. And just before that, he'd been talking about his wedding. He was having a big elaborate wedding in the Middle East, and I was trying to get myself invited to it, and so I was trying to make a good impression on him, and so this mum came in, and she'd brought this child in a pram, and I remember the child had been eating what's it crisp, and his fingers were all orange, and I was thinking, well, that's hopefully not the rash she's referring to, and so I picked up this little girl and put her on the examination couch, and the student was standing behind me, and the mum was on the other side. And I was saying, right, when you're examining a rash, you look at the size of the lesions, whether they're flat or raised, or whether you can blanch them or not. And I went into it, and he started really heavily breathing behind me. And I was thinking, how strange. I didn't notice he was a mouth breather before. I'm not quite sure I want to go to this wedding anymore. And so the breathing got louder and louder and started getting quite wheezy. And he whispered something to me. He went, "I'm allergic to cats." And I thought, that's really bizarre. Thinking, not sure that's relevant to the situation we're in, but okay, noted. And so I said, and then you check the temperature, you see where the rash started, and blah 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 blah. And he went, "No, Dr. Khan, I'm really allergic to cats." And then I thought, oh, okay. And then before I had time to do anything else, he just collapsed. And as he hit the floor, he hit the pram that the child had come in, and on the shelf at the bottom, this woman had brought in 2 cats, but they weren't in a box; they were just asleep in the bottom. And so as he hit it, these 2 cats ran out of the pram. He had a full anaphylactic reaction to it. So I had to hand the baby over to mum. Thankfully, the baby was fine. The rash wasn't
Give
serious.
him his adrenaline.
Well, I had to get the receptionist in to bring in the crash trolley, and we had to resuscitate him. And it was just like a really crazy experience. And thankfully, he made it. We called an ambulance. They took him away. We had to give him adrenaline and all of this kind of stuff. And we never found one of the cats. We never found one. So I'm not quite sure.
Even now, the cat is still
Even we
missing.
don't know what happened to that cat.
But what about the wedding?
Well, I think I've been barred from the Middle East, let alone going to the wedding, because he never came back to work. He went back to Leeds University medical, but he didn't come back to our practice. So that was that was a funny experience. And I'll just say one more, because this is another one that does make me laugh sometimes. And again, it involves a student. I don't know why, I always seem to have a witness to these moments. But I had a GP trainee, and when they start in August, they have 2 weeks of induction, and they follow you around everywhere you go. And I was on call at the surgery, and I had she was very posh medical GP trainee in with me, and she was telling me about this house she was buying in Harrogate, which is a very posh part of Yorkshire, not like Bradford, and we had a really busy on call. I hadn't had lunch, but this is just kind of what you get used to, don't you, when you're on call? And so we had to go out to a nursing home to see a very unwell lady, and she was really unwell, and we had to call an ambulance for her as well. But because she was so unwell, I said to her, to the trainee, I said, when patients are this unwell, we stay with them until the ambulance arrives, just in case. So I was looking out the window and writing a letter for the ambulance crew to take with them. And the ambulance came, and I said, okay, we're in a rush because we're on call. We've got to get back to the surgery in case there's any, because there'll be a phone list waiting for me for patients to call. So we better get back. So I went downstairs to hand over to the ambulance crew. But I think I can only put it down to hunger hallucinations. But it wasn't an ambulance that came; it was an ice cream van, and I was really hungry, and I was debating to myself as to whether to order a 99 while I waited, and I did. When the ambulance did come, and I got it with like sherbet and juice, and when the ambulance did come, when I handed over the letter, the juice had all like gone down onto this letter, and it was so embarrassing handing it over, and the ambulance crew, visibly disgusted, made a point of like putting on gloves before taking over this letter. So it all kind of happens in general practice, I guess.
The rich tapestry of life in the NHS.
Yes.
Well, look, thank you very much for that discussion. Let's throw it open to the audience now, and there will be 2 roving mics, and I think for hygiene reasons, don't try and take hold of the mic. It will be put in front of you, but do ask your question. And there's one just over here. Thank you.
Hi, I'm Ram. I want to share one experience and ask a question. First, the experience is based on everything that you have said, more on the mental health side. I walk every morning from 6:30 to 7:55, time counted. I started walking from April this year, and people used to be extremely stressed. And I did a very small gesture, which was wishing everybody good morning. Initially, it was taken very in a suspicious way, but my persistence did not go off. And today, between 35 to 65 people greet me good morning, between 6:30 and 7:55. Not only that, they have become so curious to talk. So now it is not only a walk for me, but it is a company of different people at different timings of that duration. Very pleasant experience. It coincides with what you just shared about people feeling lonely and looking for the opportunities to talk to someone, and that's what I've been experiencing every morning, irrespective of the weather, whether it's rain or whether it is summer. Now the question, the pandemic has compelled the whole of the medical profession to adopt technology in a big way. So how has that been adopted, and what all challenges did you all experience? On one side, adaptation of the technology, and on the other side, delivering the service.
Fascinating question, and earlier point about interaction with people. Kathryn, do you want to reflect on that first point?
I love that. Yeah. Thank you for being that person. And I think we all need to become that person, that people are looking for connection, but everybody is just a little bit embarrassed to be the first person to make a move. It's a very British thing, I think. And one of the things that I was talking to a friend just before we started this afternoon was that people are missing their regular meetings with people they know from work. Maybe they meet in town. But one of the things that's starting to happen instead is that the local communities are starting to become stronger. So you're starting to notice that you walk past the same people every day, and they're starting to notice that they walk past you every day. And soon something really interesting will happen, is that people who you have sparked into speaking to you will start to speak to each other, because actually these are ripples of connection, and I think it's really, really important. So thank you for being the change we want to see, and I think we should invite everybody to be a little bit braver about saying good morning.
Okay. Lovely story. Do either of you want to reflect on technology?
I might say something there. First of all, I think it's great that you say hello to everyone. It's a very northern thing to do, which I love. In general practice, we did have to change the way we worked, in order to make sure people with COVID-type symptoms weren't coming into cold areas where we were seeing other patients. And so we did move to a telephone or video consultation initially for patients. I'm horrendous with technology, so the idea of video consultations fills me with dread, and having to learn about all of that stuff is tricky. And also you then have to teach it to your trainees and medical students as well. It works for some people, I think, and certainly for people who can't get to the surgery for either they may have childcare or work or something like that. I don't think it works for everyone, and it's about, right now in general practice, it's about finding that balance between who can be safely managed remotely through the technology that's there. And the technology was always there before the pandemic. We just never really embraced it because seeing patients face to face was always the gold standard. And so now we are in a very precarious situation, I think, in general practice, where we're trying to find that balance, because a lot of people can be managed remotely, but not everybody wants to be managed remotely, and we have to then find who can and who can't safely.
Okay, let's see if there's any other questions. Just one over here, thank you.
Hello, from another northerner. Basically, my sister's an ITU nurse, but she hasn't managed to carry on. So how are you going to, as an NHS, help get people back and keep people in the NHS?
Rachel.
Yeah, so I'm so sorry that that's been your sister's experience, and sadly not at all surprised. I know I have friends in exactly the same situation. I think that for many frontline staff, the last 18, 19 months have been absolutely shattering, devastating. And it's really strange because on the one hand, we had the public, there are lots of people talking, writing about heroes and angels, and it was incredibly moving to know that the public had your back. But actually, I think quite often within the trusts where we work, there was a lot of lip service to supporting staff, but not necessarily so much actual, genuine support. But by which I mean really proactively offering psychological support to staff. So for instance, I remember about 6 months after the pandemic began, talking to a palliative care consultant, and we were talking about our experiences of seeing patients with COVID in the hospital, and all of a sudden the two of us were just streaming in floods of tears, and she said to me, "Oh my God, I'm so sorry, but this is the first time I've actually told anybody what it was like." And I was sort of saying, "I know, me too. I've just been writing this on my laptop for myself, for my sanity, but I haven't actually told anyone, any colleague, what it was like." And at no point had anyone invited us, given us that opportunity. And I know so many people who went through last year just not talking about it, thinking other people are going through worse, they're going through the same, I mustn't be self-pitying, I mustn't make a meal out of this. And actually, I feel as though there's been an enormous focus within the NHS of tackling the backlog of operations, diagnostics, all of which had to be put on hold last year and again in January because of COVID. But surely it's blindingly obvious that in order to do that, you have to have a healthy workforce, and we do not have a healthy workforce. We have so many people like your sister who probably feels as though she has been forced to leave the job she once loved against her will because she feels broken and can't do it anymore. And There are so many things that could be done now to fix that. Do people need to be supported to work part-time for a period without a loss of salary so that they have time to regroup? Everybody should be provided with proper mental health support, counselling, psychotherapy if they need it. There are so many people, I'm 100% convinced, with undiagnosed PTSD. All of this could be happening now. The government could be investing in those ways in the NHS workforce and our workforce of carers. But it's not happening. It's absolutely not happening at all. And I think that's a tragedy. And I think it's going to have a really, really detrimental effect ultimately on patients, because the NHS is its workforce. And every single person like your sister who has been forced to leave, that's just a heartbreaking loss. So lots to be done.
Thank you. Now, is there another hand? Yes, just time for one more. If you could keep it quite brief, that'd be great, and our panelists brief as well. But just here, thank you very much.
Hi, sorry, just recovering from COVID, and I was wondering if any of you have had COVID, and what it was, how was your experience? It's very different, isn't it, for everybody?
Yeah. Well, I had mine. I wasn't allowed to be tested because it was back in last February, and even though my husband had been flying in and out of China and Lombardy, because he wasn't ill, I wasn't allowed a test. I was sick as a dog for a week, couldn't get out of bed, and then for well over a month, couldn't get up a flight of stairs without feeling like I'd run a marathon. And it took at least another month after that before I attempted any kind of exercise. Yeah. So shockingly different to a normal virus flu. How are you doing now? Are you on the mend?
It's been a good month, but I've got no taste.
Yeah. It comes back for most people.
Okay. Kathryn, did you or your household have it at all?
So our adult children, one's a nurse, one's a teacher. They've both had COVID, almost certainly from work. My son very early on, loss of taste, cough, fever, miserable. And our daughter a year later, so doubly vaccinated, but actually still in bed for a week and significantly unwell despite that. So I know that I'm walking on thin ice because, but I'm lucky enough not yet to have been sick.
I did get it in March 2020, so probably similar time to you. And again, no tests available. Very fatigued for a week, and then, like you, lost my sense of smell and taste. Mine, and I hope yours doesn't go on for that long, but went on for about 3 months. And it's really tricky, isn't it, I think, because you often forget that you've lost your sense of smell and taste, and you prepare a lovely meal, and then you go to eat it, and you're like, oh, well, that was completely pointless. I shouldn't have wasted my time preparing that. Yes. No, I tell you what, it comes back in funny phases. You get certain parts of taste back first, and then slowly you get other bits. Yes, that's a good sign if it's coming.
You heard it here from a GP that it does begin to slowly return.
Yes.
Taste and smell, but very very unpleasant while it lasted. Right.
But you're getting vaccinated now, are you? No,
Gives you better protection.
Yeah,
than
really good
catching
evidence.
COVID.
Really good evidence.
You will have important public health.
Yes,
You will have
do it.
immunity, but the immunity is nothing like as good from catching COVID as it is from having the vaccine. So honestly, please have the vaccine.
And the evidence is strongest for people who've had the vaccine and COVID.
Yes.
So you'll have supercharged immunity then. So definitely go and get it.
Well, really important to end our session on that very important public health messaging from both of you. So we could go on discussing. Yeah, well, thank you for your question very much. It's very important. So just to say thank you very much. We could carry on the discussion for a long time. There's so much we could have got to, but I'm afraid our time's run out. The 3 authors will be signing their books down at the bookstall at the bottom of the escalator, so do go along there. and buy the books if you can, and have a chat with the authors. So just as we clapped for carers last year, let's give a big round of applause to Kathryn, Amir and Rachel for joining us for this discussion. Thank you very much. Thank you. That's it, folks.
We're waiting for